And I'd have to say that all of the centers were high volume centers, colorectal surgeons, so I think that they were very good surgeons. But I think it points out that probably in Crohn's disease especially, that the leak rate is probably a bit higher than other resections, but 7% I think is probably the right, or is realistic. And then after all of this, that we didn't show any difference in the recurrence rate. So in the end-to-end anastomosis, the endoscopic recurrence rate was 42% versus 37%, and the symptomatic was 21% versus 22%. And so you can see that the difference in the endoscopic rate was 4%. With fairly wide confidence intervals, and we were criticized about that, criticized that we didn't have enough power or whatever. But I think that it really points out when we look at the symptomatic rates that, that we did some statistical analysis to see how many more patients would be required to actually show that there was a significant difference, and it was very large. So I have to say that I think we've answered the question, but others have had concern about that. But all I'd say to them is you do a trial and see how well you could do it. We did look at multivariate analysis about factors affecting recurrence, and we did show that previous resections, if patients had had a previous resection, they were at more risk for developing both endoscopic and symptomatic risk. And we also had some patients who received azathioprine therapy, and you can see here that their risk of recurrence was significantly decreased. And that was sort of an interesting finding that we found. Now, I thought I'd throw this in since I think this is mainly a GI audience, that our secondary research question was to answer whether the CDAI would be suitable for use as a single outcome measure to determine postoperative recurrence, and if so, what score best discriminates symptomatic recurrence from remission. So for our study, what we used to define clinical recurrence was they had to have endoscopic recurrence plus symptoms that in the view of their gastroenterologist or physician that was severe enough to warrant treatment. And so Tom Walters, who's actually a student working with me, has looked at this, and you can see here that those patients who had no recurrence, no endoscopic recurrence, no symptomatic recurrence, that their mean CDAI level was about 75, I think, something like that. If they had endoscopic recurrence, but by our definition, no clinical recurrence, that the endoscopic recurrence, or the mean CDAI was, I think, about 85. And then if they had what we considered a symptomatic recurrence, the median CDAI was 215. We then made an ROC, or receiver operator curve, to look at where the best cut point was, where we would say that it would be the best defining point to say who had recurrence and who didn't have recurrence. And you can see that the area under the curve was quite good. It was 0.8. And the in our points there, looking at the two red lines that you can see there, that one of them was 137 and the other one was 161. So the mean value was 148. And as all of you know, that as gastroenterologists, that the cut point for a CDAI is about 150 between symptomatic disease and asymptomatic disease. So we were pretty interested that that is what we found. However, when we looked at that, the positive predictive value was about 60%. And so we would have misclassified a large number of patients. And so our conclusion was, although the CDAI works pretty well with a cut point of 150 in differentiating symptomatic from asymptomatic recurrence in the postoperative setting, that the CDAI alone is not a suitable tool for replacing a combined clinical and endoscopic evaluation as a single outcome measure in the assessment of postoperative disease recurrence. And we felt that it's important that patients still need to be endoscoped to determine whether there's endoscopic recurrence. We think that we did pretty well with our perhaps less rigorous definition, that is, symptoms warranting medication, and that it correlated well with the CDAI. So just going on then, what about laparoscopy? That some people have postulated, in fact, that laparoscopy may make a difference. In fact, that the recurrence rate may be higher because there's less stimulation of the immune response in laparoscopy. The first study that was done was by Jim Fleshman and his group, and they retrospectively reviewed 69 patients who had a laparoscopic ileocolic resection to 50 who had an open ileocolic resection. And they found, in fact, that the recurrence rates were lower in the laparoscopic group compared to the open group. But you can see that the follow-up was different in those two groups, and also that it was a retrospective study, and they didn't have necessarily similar follow-up. So in our trial, we also looked at it. Patients were not randomized to laparoscopy, but we did have follow-up in the patients, and we found that there was, again, no significant difference, 51% in the laparoscopic group compared to 61% in the open group. So maybe a small difference, it certainly wasn't statistically significant. So in summary, there's little evidence that any surgical maneuver is effective in decreasing the risk of recurrent Crohn's disease, with the exception of constructing a stoma rather than doing an anastomosis. And so the general principles that we should have a bowel-sparing philosophy, remove all of the gross disease or macroscopic disease, resection margins of a few centimeters, and that the anastomotic type should be according to surgeon preference. So the question then is there anything effective? And I think that we as surgeons need to pay much more attention to getting our patients to stop smoking. Overwhelmingly, the evidence suggests that smoking is associated with recurrence of Crohn's disease. These are retrospective reviews, 10 studies in total. They define smokers as 5 cigarettes per day times 10 years, or 7 cigarettes per day times 5 years, and they found an approximately 2-fold increase in recurrence rate in smokers. There was a dose-dependent relationship. The effect was most pronounced in women, and ex-smokers still seem to have the same risk as smokers. And I pointed out that in our study that about 35% of people in our study were smokers, and in the Canadian, I think the US population, about average is about 20 or 25%, so there was a higher number of smokers. So, I think this is the thing that we really don't pay enough attention to, and we need to. So what about maintenance therapy? So I'm not going to go through the trials, because I'm sure all of you are gastroenterologists and you know the data much better than I do. But there now are a number of trials that have been done in a number of medications.